Diagnosing and managing Lyme disease can be really challenging, but early and adequate treatment is the key to reducing the risk of long-term morbidity. My name is Cruikshank. I'm a GP and I am the RCGP Clinical Champion for Lyme disease. So the guideline aims to raise awareness amongst both clinicians and the general public, and to ensure that patients presenting with confirmed or suspected Lyme disease receive early and consistent treatment. The Guideline Committee has acknowledged the poor quality evidence of both diagnosis and management and has made recommendations for further research within the UK. So Lyme disease, or Lyme borreliosis as it's known, is a bacterial infection caused by the spirochete Borrelia burgdorferi, which is transmitted to humans by the bite of an infected tick. The name Lyme disease comes from the town of Old Lyme in Connecticut, where in the 1970s a large group of children were diagnosed with a form of juvenile arthritis. However, the neurological form of the disease has actually been recognised in Europe since the 1800s. In the UK, there are 3 genus species of Borrelia, and the symptoms presenting in the patient may well depend on the genus species with which they've been infected. And this could vary from neurological symptoms, cardiac symptoms, or arthritic symptoms. In the USA, arthritic symptoms are much more common, whereas in Europe it tends to be neurological symptoms. Ticks are small blood-sucking arthropods which are found throughout the UK. During the lifestyle, they pass through 3 stages of the larva, the nymph or the adult. They're carried on deer, small mammals and birds, and they're generally found in woodland, moorland, grassy areas, but they can also be found in parks and gardens, even in urban areas such as London. They're more active between April and October, and the incidence of Lyme disease in the UK tends to be higher in around June, July. UK studies have shown that infection rates in the ticks could vary between 0 and 12% on average. So a tick bite in itself will not necessarily cause Lyme disease. Tick bites are painless and they may go unnoticed by the patient. Infection is more likely to occur the longer the tick has been attached, but there is no proven minimum time required for infection to pass into the host. And traumatic removal of the tick can in itself increase the risk of infection. So early diagnosis and adequate treatment provides the best chance of cure, but delayed diagnosis can result in long-term symptoms. And to diagnose Lyme disease, clinicians need to have a high index of suspicion. The incidence of Lyme disease in the UK is unknown, as it is not a notifiable disease. We do know that there are more cases in the southeast, southwest and in Scotland. Public Health England reports 1,600 serology confirmed cases a year, and estimates of the incidence, the overall incidence, vary between about 3,000 and 8,000 cases a year. It's also important to bear in mind that some of these cases will be diagnosed late, and these patients may suffer long-term illness as a result. The NICE quality standard has recognised the need to increase public awareness and knowledge regarding ticks and Lyme disease. They're specifically keen for patients to be aware of the need for tick avoidance, how to do tick checks, how to remove ticks correctly, and when to seek medical advice for the early symptoms of Lyme disease. Public Health England has provided a lot of education for both the public and clinicians, and the NICE guideline and the quality standard have endorsed the RCGP Lyme Disease Toolkit, which provides information for both practices and the general public. There's also an emphasis on the need for public education to be provided by recreational and other outdoor groups, as well as organisations such as the Forestry Commission, the military, and schools themselves providing information for pupils and parents. Removal of ticks is a particularly important area for patients to be aware of. The tick should be removed as promptly and as carefully as possible. Ideally, people should use either a tick twister, fine tip tweezers, or a tick card. They should avoid using anything that crushes or traumatizes the tick, such as much wider tooth forceps, and they should avoid smothering it in oil or nail varnish, which again can cause it to become traumatized, which may result in it regurgitating its contents into the host. Once the tick has been removed, then the skin should ideally be cleaned with an alcohol wipe, and the person should be aware of the need to monitor for any signs of either an erythema migrans rash or systemic symptoms in the next 4 weeks or more. So the most common feature is probably the erythema migrans rash, and this occurs when there is just very localized infection. But the rash doesn't occur in all patients. It probably occurs in around 70% of cases. It is diagnostic, and if an erythema migrans rash is diagnosed or suspected, then the guideline advises that treatment is commenced without any need for a blood test. Since in the case of an erythema migrans rash, the clinician can make a clinical decision and will not require a blood test, it's really important that this is recorded appropriately in the clinical notes. This can actually be recorded either as an EM rash or suspected EM rash, but it will be very helpful in the long term when looking at further evidence of the overall incidence for the UK. It will also be helpful for the future should a patient develop further symptoms and will provide evidence of previous Lyme disease diagnosis. In the early stages, even with or without an erythema migrans rash, the patient may then start to develop systemic symptoms, which may be mild or severe. They could just mimic a flu-like illness with possibly a mild fever, migrating aches and pains, headache, neck ache, shortness of breath potentially, occasionally chest pain, sometimes some early neurological symptoms. Fatigue is also a big factor, and brain fog may occur, but patients will describe brain fog either at quite an early stage or sometimes later in the illness. The risk at this point is that the symptoms could mimic any other infection, and patients are sometimes diagnosed with summer flu and fail to return for follow-up when their symptoms don't resolve. So after the early couple of weeks, if a patient isn't treated, they may go on to develop a more late disseminated stage of the illness. And this could occur weeks, months, or even years after the initial infection, and can result in multisystemic symptoms, which might affect the nervous system, the heart, joints, eyes, skin. And at that stage, it might be very difficult to diagnose because there are so many different symptoms involved. It can also cause neuropsychiatric symptoms. It could be misdiagnosed as chronic fatigue syndrome. One of the other key symptoms in an early stage could be a facial palsy, and this could occur early in the illness or at a later stage. There is some evidence of mortality related to Lyme disease, particularly cardiac symptoms. There also appears to be an increased risk of suicide. If the diagnosis is suspected, but the clinician is unsure, then blood sample can be sent to the local lab for an ELISA blood test. If this test is positive or equivocal, then the sample will then be sent on to the National Lyme Reference Laboratory for further testing, specifically for a Lyme blot test. It's important to remember that a negative test does not exclude the diagnosis, particularly in the early stages. And diagnosis should be made based on a combination of clinical symptoms and serology. The NICE guideline advises that if the initial test taken within 4 weeks of a bite is negative and Lyme disease is still suspected, then a further test should be carried out 4 to 6 weeks later. However, the guideline also advises clinicians that if they suspect Lyme disease, they should initiate antibiotic treatment without waiting for a test result. In the majority of cases, the diagnosis can be made fairly simply in primary care. And once a decision to treat has been made, patients or parents should be involved in that decision and the management plan. The usual treatment is in an initial 3-week course. For adults, that's normally doxycycline 100 milligrams twice a day, first line. For children of 9 years and older, it's also doxycycline under 9 years, or in patients who are pregnant, a high dose of amoxicillin is usually first line. If a patient remains symptomatic after 3 weeks, then consideration can be given to a further course of treatment. Obviously, it's important at this point to reassess and be sure that was the diagnosis isn't being correct. If at the end of the second course the patient is still symptomatic, it may be necessary to consider referral to a specialist. If a patient has particularly severe symptoms within primary care, such as cardiac or neurological symptoms, then if necessary, emergency or urgent hospital admission or referral may be required. In children with symptoms other than a rash, it is important to access advice from a local paediatrician. In adults, referral to secondary care may depend on the symptoms. The NICE guideline and the NICE quality standard has endorsed the RCGP Lyme Disease Toolkit, and we hope that GPs will find this a user-friendly tool to access very easily within the surgery for details on diagnosis and management. Diagnosing and managing Lyme disease is challenging, and GPs have a key role to play. I hope you found this film useful, and thank you for watching.